the Maryland Department of Health and Mental Hygiene, Hospital Breastfeeding Policy, Maternity Staff Training Program. Promoting Breastfeeding During Pregnancy, Session 4. Objectives. Name 2 reasons why breastfeeding is the normal way to feed infants. Identify teaching points to share with pregnant women. And state the American Academy of Pediatrics breastfeeding recommendations. Until about 100 years ago, everyone breastfed. Breastfeeding was portrayed in art, described in literature, and was a normal part of our society. Today, formula feeding is thought to be a cultural norm. However, the clear majority of mothers today initiate breastfeeding, showing that breastfeeding is the true norm. Formula companies go to great expense to market formula so that the general public views formula as the norm. In speaking with pregnant women and their families, we need to convey the message that the normal infant feeding is breastfeeding, and any feeding expectations need to be based on what we see with breastfed infants. Most women make a decision regarding breastfeeding early in their pregnancies, or even prior to conception. Healthcare providers need to discuss breastfeeding with patients early in prenatal treatment in order to encourage more women to breastfeed exclusively for the first 6 months of life. More than half of one study population reported having made their decisions by the end of the first trimester, and many more may have decided prior to the last trimester of pregnancy. As healthcare professionals, we are part of the team that provides support for women prenatally, in the hospital, and postpartum. Research shows that professional encouragement significantly increased breastfeeding initiation. Sue and colleagues found that overall, women are more than 4 times more likely to initiate breastfeeding when an educated professional promoted breastfeeding. Further research found that when you, the professional, promotes breastfeeding, low-income, young, or less educated women are 3 times more likely to breastfeed. African American women are 5 times more likely, and single women are 11 times more likely to do so. Let's find out more about how you can make a difference. Enthusiastic support and involvement of physicians and nurses in the promotion and practice of breastfeeding is essential to the achievement of optimal infant and child health, growth, and development. Keep in mind that your own personal beliefs and attitudes about breastfeeding affect the way you promote breastfeeding. It is essential that you think about your own feelings about breastfeeding and find ways to communicate only the philosophy provided within this educational program. A great way to start a conversation with your patient would be to ask, "What have you heard about breastfeeding?" This open-ended question allows her to direct the conversation by elaborating on any issues of concern. Research has revealed that the 5 most common barriers to breastfeeding are 1. Lack of confidence, including fear of not producing enough milk. 2. Embarrassment to breastfeed in public or in front of others. 3. Loss of freedom. 4. Concerns about diet, health practices, and discomfort. And 5. Influences of family and friends. Many times before you have even spoken to a mother, she will have concerns about breastfeeding. She will have doubts that may have developed over time and barriers that are preventing her from feeling that she can be successful at breastfeeding. She may be concerned about the pain with breastfeeding or breastfeeding upon return to work. Research shows that it is more effective to explore a woman's beliefs prenatally about breastfeeding than to give her information about why breastfeeding is important, as most women are already aware of the advantages of breastfeeding. Asking the open-ended question, "What have you heard about breastfeeding?" allows the healthcare provider to learn what the patient knows, discover any barriers that exist, and correct misconceptions to allow the patient to move past her barriers with initiating breastfeeding. Before we can counsel a new mother, it is essential to gather information from her. We can learn a great deal when we ask appropriate questions and listen to others. The three-step counseling method provides the key elements needed for an effective assessment and education. Ask open-ended questions to elicit a participant's perceptions. An open-ended question cannot be answered with a simple yes or no, thus opening up a conversation. Acknowledge a woman's concern and reassure her that these feelings are normal. Acknowledging her concerns does not mean you agree with her. It simply means that you have heard her and that she is safe to reveal this information to you. Now that you know what concerns your patient, you can direct your education toward these concerns. Since you have validated her concerns before this step, she has relaxed with you and it is now open to hearing what you have to say. Asking an open-ended question is a method used to get a mother to talk about her concerns. An open-ended question gives the mother the freedom to alter her perceptions. Asking a closed question, which can be answered with a yes or no, does not give you information about what the mother's concerns are. In addition, it can lead the discussion in the direction of what the healthcare provider feels is important, which may not be the information the mother needs to know in order to overcome her barrier. Validating feelings is a key component necessary for two-way dialogue to continue. It establishes rapport, it tells the mother you are really listening to her, and it increases the effectiveness of your teaching. During this step, you will need to respond to the mother with a statement that lets her know you've heard her and that it's okay for her to reveal this information. Some examples of validation statements are, "I've heard many mothers say that." "I think you are going to be a good mother." "I remember thinking that too." Once the mother hears that it's okay for her to feel this way, she opens up and is ready to hear the education that you have to provide. Now you are able to provide your patient with targeted information based on what she has told you. It is important to provide evidence-based, accurate, and consistent information to prenatal and breastfeeding mothers. Doing so will help them learn and reinforce confidence as they interact with a variety of staff through the multiple shifts. If necessary, use an interpreter to communicate and discuss any cultural, religious, or family traditions that affect the patient's decision to breastfeed. Consider the cognitive ability of the client when discussing breastfeeding. Use terminology that she can understand, avoid the use of abbreviations, and include any family members or supportive persons in the conversation. For teen parents, consider the developmental stage of the mother and address issues such as school, proper nutrition, body image, financial resources, support from friends, and social activities. Educational programs had the greatest effect of any single intervention on both initiation and short-term duration of breastfeeding. While patients in the hospital are often educated on an individual basis, group education is another option. In 2003, the U.S. Preventative Services reviewed 30 randomized and non-randomized controlled trials and 5 systematic reviews of breastfeeding counseling. The results found that group education has been shown to have significant positive impact on breastfeeding duration. They further found that this is beneficial when there's a sharing of concerns and experiences combined with hands-on skills teaching. Support groups are an effective way to do this. The decision to initiate breastfeeding is influenced more by knowledge gained from seeing breastfeeding than theoretical knowledge. Including videos that show babies breastfeeding offer opportunities for prenatal and newly postpartum hospitalized mothers to see breastfeeding. Referring patients to support groups after discharge provide continued benefits for education, support, and opportunity to interact with other breastfeeding mothers and children. Include referrals to appropriate community resources, such as WIC or La Leche League, to ensure that mothers have support after leaving the hospital. All of us in healthcare must work collaboratively to ensure that women receive accurate and sufficient information throughout the perinatal period. In doing so, women will be able to make a fully informed decision about infant feeding. Yet people do not always adopt healthy behaviors based on information. Knowledge isn't always enough. Effective counseling principles help mothers explore ways to work breastfeeding into their lives. Human milk has a composition that is unique among mammals. It is ideally suited to the human infant's needs because it is species-specific. The proportions of components in human milk and their bioactivity and interaction with one another make it impossible to replicate human milk. Other mammalian milks may have similar components, but they are not identical. Researchers are attempting to unravel the complexity of human milk and the functions of its many component parts. Human milk is the gold standard against which formulas are measured and manufactured. Any substitute for human milk is substandard. The proportions of protein, carbohydrate, and fat found in human milk are different than what is seen in formulas. The ratios of various types of proteins, whey versus casein, are not exactly replicated. Formula companies have altered cow's milk substantially in an attempt to make it more compatible with supporting life in human infants. It is not recommended that infants consume cow's milk before 1 year of age because of the many gastrointestinal, renal, and other problems associated with its higher protein, lower fat content compared to human milk. The hazards of infant formula and the higher morbidity and mortality associated with formula feeding are directly related to it being non-species specific. Breast milk changes in composition throughout the feeding, throughout the day, and throughout the duration of the breastfeeding relationship to meet the unique needs of each individual baby. The milk a mother makes for a newborn is different from the milk she makes for an older baby. There are many research studies that show the many benefits that breastfed babies attain. Babies who were exclusively breastfed were 23% less likely to have acute otitis media compared with those who were formula fed. Infants with a family history who were exclusively breastfed for at least 3 months reduced their incidence of atopic dermatitis by 42%. One English study found infants who were breastfed had a 64% reduction in the risk of non-specific gastroenteritis compared with infants who were not breastfeeding. Other digestive disorders, such as Crohn's disease and colitis, have been linked to suboptimal breastfeeding. 7 studies reported an overall 72% reduction in the risk of hospitalization due to lower respiratory tract diseases in infants less than 1 year of age who were exclusively breastfed for 4 months or more. Studies have shown a reduction in asthma by 27% in those who were breastfed for at least 3 months of age but had no family history of asthma. A reduction by 40% was found among breastfed infants with a family history. There is an association between a history of breastfeeding and a reduction in the risk of being overweight or obese in adolescence and adult life. Breastfeeding for at least 3 months reduced the risk of type 1 diabetes compared to breastfeeding for less than 3 months. Breastfeeding in infancy has been found to be associated with a 39% reduced risk of type 2 diabetes later in life. Studies have shown an association between a history of breastfeeding for at least 6 months' duration and a reduction in the risk of childhood leukemias. A history of breastfeeding was associated with a 36% reduction in the risk of sudden infant death syndrome compared to those without a history of breastfeeding. Breastfed infants have the potential to reach an IQ at 7 to 10 points higher than their non-breastfed counterparts. Studies have shown that for up to 2 years postpartum, mothers who breastfed had less than a 3-pound weight change from their pre-pregnancy or first trimester weights. In women without a history of gestational diabetes, each additional year of breastfeeding was associated with a 4% reduction in the risk of developing type 2 diabetes. There is an association between breastfeeding and a reduced risk of breast cancer. Women who breastfeed for longer durations have greater reduction in the risk of premenopausal breast cancer. This effect also applies when adding the duration of breastfeeding among each child a mother has breastfed. Women who breastfed had a 22% reduction in the risk of ovarian cancer compared with those who had never breastfed. Risk reduction appeared greater for longer durations of breastfeeding per child. Other studies have suggested associations with decreased risk for osteoporosis and rheumatoid arthritis. If 90% of women in the United States would breastfeed exclusively for 6 months, the United States would save at least $13 billion per year and prevent 911 deaths. Women who return to work while breastfeeding take less time off from work to take care of a sick child. Studies found higher productivity because parents can work without worrying about their sick baby. Breastfeeding leads to better infant health, thus fewer infant doctor and hospital visits, fewer health insurance claims, and less family leave used for parents to stay home to take care of their sick baby. According to a 10-year study, it was estimated that families who followed optimal breastfeeding practices saved more than $1,500 in the first year alone on infant formula expenditures. Naturally, with the current increase in overall consumer prices, this savings would be much higher. Exclusive breastfeeding means that breast milk is the baby's only food. With exclusive breastfeeding, the baby is given no food or drink other than breast milk unless medically indicated. Even one bottle of formula in the first few days of life may negatively impact the protective effect of breast milk and maturational effects of the infant's tissues and organ systems by permanently affecting the pH of the intestine. Benefits derived from the social interactions between mother and infant during breastfeeding sessions cannot be discounted. The American Academy of Pediatrics recommends that all infants exclusively breastfeed for the first 6 months of life. Exclusive breastfeeding is sufficient to support optimal growth and development for approximately the first 6 months of life and provides continuing protection against diarrhea and respiratory tract infection. During the first 6 months, even in hot climates, water and liquids other than breast milk are unnecessary. The closer to exclusive breastfeeding one comes during the first 6 months of life, the better the protection and development of the infant. There is no upper limit to the duration of breastfeeding and no evidence of psychological or developmental harm from breastfeeding into the 3rd year of life or longer. A detailed prenatal assessment and history is needed to examine any possible risk of breastfeeding problems a patient may have. A review of any previous deliveries or breastfeeding problems may help reveal breastfeeding concerns. Sheehan syndrome is a very rare condition that can occur in a woman who bleeds severely during childbirth. Severe bleeding during childbirth can cause tissue death in the pituitary gland, causing the gland to lose its ability to function properly. This would lead to a lack of milk production. History of surgical procedures such as breast reductions, augmentation, biopsies, lumpectomies, abscess drainage, or previous breast trauma caused by thoracic surgery or placement of chest tubes in infancy may be a problem for some women. During pregnancy, your patient should have experienced changes to her breasts, which suggest occurrence of breast development necessary for lactation. During the breast examination, take note of the normal breast changes that should be occurring and take this opportunity to teach the patient about the changes she has been experiencing. Changes in the size of the breast, sensations of tenderness and fullness, and or darkening of the areola are all positive signs that the breast is continuing to develop so that it will make milk. While some women leak colostrum during pregnancy, others do not. Either situation is normal. There are many normal variations of the physical characteristics of the breasts and nipples of women. Flat and inverted nipples are common among first-time mothers, comprising approximately 10% of women who intend to breastfeed. Some women may have nipples that appear to be flat but evert with a pinch test, used to assess the shape of nipples. Breasts with flat or inverted nipples may have fewer or abnormal ducts. Abnormal nipples that may present a challenge to breastfeeding include flat, retracted, or inverted nipples. Breast exams should focus on any thoracic surgeries and chest tube placements, previous breast surgeries such as breast reduction or enlargement, and skin conditions such as lesions, trauma to the nerves, which could impede neurological transfer of messages to the pituitary gland, thus milk production might not occur, and breast cancers. Other breast characteristics to note are unusually shaped breasts or discrepancies in the size of the breasts, which can be a risk factor for decreased milk production. A flat nipple does not move forward or backwards with the pinch test. The top two pictures on this slide show an inverted or retracted nipple. It moves backwards with the pinch test in comparison to an everted or ideal nipple. There is no need to wean a nursing child if the mother becomes pregnant. Breastfeeding two children from separate pregnancies is called tandem nursing. Nipple soreness is often reported when nursing during a pregnancy. Extra care with positioning and latch may be helpful to the mother. Her milk may decrease in amount and change in flavor during mid-pregnancy. This is normal, and the mother should be encouraged to continue if mutually desired between her and the child. A supplemental feeding plan may need to be developed for the nursing child if this creates discomfort or results in lack of nutrition. Abrupt weaning should be avoided, as it can lead to physical pain for the mother and emotional discomfort for both mother and child. If the mother chooses to wean, she should be encouraged to gradually do so by dropping one feeding at a time over the course of several days to weeks. The goal of prenatal education is to convey a few simple target messages. 1. Breastfeeding is desirable and achievable. 2. Professional help and community support are available. 3. Breastfeeding should be comfortable. 4. Exclusive breastfeeding is important. 5. Prenatal nipple and breast preparation have not been proven effective. Often, pregnant women ask how they should prepare their nipples for breastfeeding. While their bodies prepare for breastfeeding, the best thing expectant mothers can do is take classes and learn about breastfeeding so they know what to expect. Even when mothers verbalize that they choose to combination feed, it's important to convey that exclusive breastfeeding for the first few weeks will establish their milk supply so they can achieve their goal of combination feeding, or doing both.